A very good evening, everyone. Thank you so much, Dr. Sumit, for my mentors are here. So it's really a matter of privilege for me. So today I'll be talking on intraocular tuberculosis and the lookalikes. Well, it's a huge topic, so I'll try to keep it very practical and clinical. I have no financial interests. So I hope, yeah. So, tuberculosis, as we know, is an infectious disease with protein manifestations. It is caused by Mycobacterium tuberculosis, pathologically characterized by a granuloma formation. It predominantly affects the lungs, but it has extra pulmonary manifestations. And why the TB? Because it is actually a global emergency. It is the most common cause of morbidity and mortality worldwide, and the annual worldwide incidence is on the rise, and it is 8.7 million, as we can see on the WHO site. And on the Indian website also, it was reported as 21.4 lakh TB cases were notified in India in 2021, which was 18% higher than 2020. So definitely India is a TB endemic country. Post HIV era, the extrapulmonary tuberculosis is on the rise, and from the blood, it can spread to any part of the eye, as we can see in the diagram here. Some studies they have gone on to see the patients, like 10,000 patients were reviewed, and it was found that 1.4% had ocular tuberculosis. In India, Dr. Jyotirmay Biswas and group from Shankar Nethralaya, they have seen amongst 1,005 patients with active TB were reviewed, and it was found that 1.39% had ocular tuberculosis. Also, out of 1,273 uveitis patients, 0.39% were ocular TB. So TB can have various manifestations like anterior uveitis, intermediate posterior uveitis, retinitis, choroiditis, neuroretinitis, endophthalmitis, and panophthalmitis. So if a patient like this presents with hypopyon, posterior synechiae, mutton fat KPs, cope nodules or granulomatous nodules on the iris, definitely it's a referral to our uvea friends. Also, conditions like this, like Eales disease, serpiginous choroiditis, vasculitis, these cases go to retina consultants. So, where does our role as an ocular oncologist comes in? Our role comes in when a case like this is referred, and when we see an isolated lesion like this, which can be a mimic of a lot of other choroidal lesions that we see in the eye. It is important to recognize the granulomas and differentiate it from other conditions. So, I'll be taking you through the same in the slides to follow. These are the various mimics that we can get of the choroidal granuloma. So choroidal involvement happens through hematogenous spread of the infection from the blood to the choroid, as in any other systemic disease. And hence, we have a long list of differential diagnoses of amelanotic choroidal lesions like leiomyoma, posterior scleritis, granulomas, METs, amelanotic melanoma, osteoma, hemangioma, and choroidal detachments. So what I would like to say is you should start always from the beginning. History can give us many clues. Well, if a person has systemic TB, of course, if we are looking at a choroidal lesion, we should think in that terms. If a patient has a systemic cancer history, if we are looking at a choroidal lesion, we should actually think about a choroidal METs. Second, examine the patient and not just the eye. So you have to see the lymph nodes, the systemic evaluation, and the other things that we have to see in this, and not just the eyes that we are examining in the patient. Before you peep into the eye, definitely do gonioscopy, intraocular pressure measurement, the anterior segment evaluation, and then only dilate the patient. When we dilate, as our mentors have taught us, we should look at the location of the tumor, multifocality, the color of the tumor, the size, the shape, the surrounding SRF, and the secondary changes that the tumor has caused in the surface. And then we investigate further with B scan, autofluorescence, fluorescein fundus angiography, ICG, OCT, or a PET scan. So a lesion like this, if we go systematically, definitely we can clinch the diagnosis and treat the patient appropriately. So if we see a lesion like this, which is a yellow elevated choroidal lesion with surrounding SRF, it can be single, it can be multiple, it can have vitritis associated. It is hyperfluorescent on AF, and on B scan, it is like a dome-shaped mass with medium to high internal reflectivity. So this can point us towards choroidal granuloma. When we do an OCT, on OCT it shows an elevated choroidal lesion with surrounding SRF, and FFA will show hypo or late hyperfluorescence with staining. Another case is like a case like this, where there's a yellow tan color lesion with subtle pigmentation. Well, in such cases, we should think about choroidal melanoma or amelanotic melanoma. And definitely remember the mnemonic: thickness, fluid, the surface, the orange pigment, and the other manifestations that we have been taught for the choroidal melanoma. When we see the B scan, if we see a collar stud appearance, of course, it's a quite characteristic feature of choroidal melanoma on a B scan. So it can be dome-shaped with hyperreflective lesion, which has a moderate to low internal reflectivity. On OCT, there'll be a gentle dome-shaped lesion with smooth surface topography with subretinal fluid. It can have shaggy photoreceptors, disruption of the outer retinal layers, and complete loss of choriocapillaries. What about a very subtle choroidal lesion like this? The patient was symptomatic and was complaining of an inferotemporal scotoma. So there was a lesion in the choroid. When we do an autofluorescence, it is hyper fluorescent. And when we do a B scan, there's a very subtle choroidal lesion, which is echogenic. It can be associated with secondary retinal detachment. It has a lower height to base ratio and high internal reflectivity. And also the patient gave us a history of systemic breast cancer, and he was under treatment. So, of course, we are looking at choroidal mets. So, this is another differential that you should keep in mind. This is another picture of a choroidal metastasis. When you do an OCT, an EDI OCT, the plateau, it has a plateau surface, shaggy photoreceptors, and subretinal fluid. It will have a typical irregular, lumpy, bumpy anterior contour with anterior compression of the overlying choriocapillaries and posterior shadowing. What about a lesion like this? So, this we are talking about choroidal lymphoma. On OCT, it has a typical undulating cystic tumor surface with overlying subretinal fluid. Another case, so if you look at an orange-red lesion like this, and if we look at the patient who appears like this, of course, we are looking at choroidal hemangioma. So you have to measure the intraocular pressure, you have to see the anterior segments for other findings of Sturge-Weber. And on B scan, it will show acoustic solidity with high internal reflectivity, diffuse hemangioma, which can show diffuse marked thickening of the choroid, whereas the circumscribed version can show or appear as a plecoid or an oval mass. On fluorescein angiography, early lacy mild hyperfluorescence in the pre-arterial or the early arterial phase is seen, and diffuse intense hyperfluorescence in the late phase is seen. OCT will show us a smooth, gentle sloping of the choroidal mass with overlying SRF, and expansion of the medium and the large size choroidal vessel, and no compression of choriocapillaries will be seen in the OCT. What about a lesion like this? It's a 40-year-old female, absolutely healthy, and we see an orange-red lesion inside the when we see the fundus. And the B scan appears like this. Any guesses? Yeah, so what we are looking at is a choroidal osteoma, and it is the B scan is showing like a plaque-like lesion, echogenic foci, and acoustic shadowing. So this is another differential that we should keep in mind. Osteoma will have an early patchy hyperfluorescence with late diffuse staining. If CMVM is present in osteoma, which it can have, there will be leakage seen in the fluorescein angiography in the late stages. On OCT, the RPE and external retinal layers abnormality will be found, and if macular neovascularization is seen, SRF will be present. Another slide that I would want to leave you with is this, which is another differential, which is VPRT, vasoproliferative retinal tumors. So as we see, choroidal lesions can be confusing. If we keep a systematic approach to the case, it can help us narrow down our differentials, and examining the patient as whole and systemic evaluation can help us clinch the diagnosis. So once we have made, just a word about the treatment of tuberculosis, if you have made a diagnosis of tuberculosis, we can go about Montus testing or quantiferon TB gold test, which is another screening test, a chest radiograph, or a AFB microscopy of the specimen. Mycobacterial culture of the specimen is the definitive diagnosis, or isoniazid diagnostic testing. Without microbiological confirmation, which can be challenging to obtain, diagnosis of intraocular TB mostly remains empiric, and the response of ATT may be the only definitive evidence of TB, and especially in a country like India, we should be in contact with our internist friends to treat such patients. The treatment comprises of HRZE and 4 to 7 months of HNR. If there's a paradoxical worsening on starting of ATT, we should keep the role of corticosteroids in mind. Also, while starting an anti-tubercular treatment, a role of an ophthalmologist is important, because most of the drugs can cause optic neuropathy, decrease in visual acuity and color vision, and centrocecal scotoma. So baseline examination of the eye in detail is absolutely essential. Also, a word about collaborative ocular tuberculosis studies spearheaded by the PGI group. It can help us direct in the treatment of these patients. and the results can be very gratifying. Thank you so much for your patient listening.